It gives me great pleasure to introduce our next speaker, Dr. Ethan Booker, who is going to speak with us regarding many great things that are going on, not only at MedStar, but also in other domains in terms of connected care. And it really gets back to our distributed care delivery network and really how we can tie all these various components together. And it's through the use of innovation and technology to really do that effectively. Ethan joined our group back in 2005 as a clinician at the hospital center. In the earlier part of his career, was very involved with the MedStar transport team and leading many initiatives there. And more recently has been involved as the medical director of the MedStar Telehealth Innovation Center, as well as the medical director of the MedStar eVisit program. So it gives me a great pleasure to welcome Dr. Ethan Booker.
Thanks, John. Thanks for coming back inside. I'm what stands between you and lunch and going back outside, so I'll try to be brief and entertaining. So I was in med school in 1999 when the first Matrix movie came out. This is actually from the second Matrix movie. This is Zion Control. And when Bill Frona asked me in 2014, do you think that we can make like an EICU kind of module where you're like remote and doing provider and triage? I said yes, having no idea if we could actually do that. And then within a couple of months, this is actually what I envisioned. If you'll remember the movie, the like actual real Zion is like underground. It's like a cave, and it's dirty, and it's kind of loud with machines, and it probably smells really bad, which evokes a certain imagery that we're probably familiar with. But Zion Control is this pristine, ergonomically perfect environment in which a team is working collectively with a bunch of technology to communicate throughout an entire system. I think it's a terrific analogy, and it also looks really cool. So the sort of promise of telehealth, right, that we're going to use technology to connect from here to there has been present for a really long time, right? This is not recent. Nikola Tesla said this in 1926. I think the most, it's incredibly prescient, except for the fact that he thought that men would still be wearing vests. So other than that, totally accurate, which is kind of amazing, right? But you know, the reality is that in life, especially in healthcare systems, change is hard. But another genius suggests that perhaps change is necessary. So I'm going to tell you a story about Dave. That's Dave's head on the far left over there. I'm sure that if any of you got out your phones and scrolled through it, you would all have these in your phones, right? So Dave's my neighbor. Like everyone in DC, he's a lawyer, and his wife's also a lawyer, also like everybody in DC. And they moved into a house right across the street from me back in 2010 with their little boy. Before we were friends, Dave is on the playground with his kid, smacks his head across the chin-up bar, opens up a gash across his head, scoops up his kid, drops him off at home, and walks to Howard Hospital, which is like right down the street. Waits for like 6 hours, gets his laceration sutured. He's not sure if somebody said something about concussion maybe. Goes home, doesn't have follow-up instructions. His wife, a lawyer, not a physician, takes his stitches out 6 days later at the kitchen table. Right? That's a terrible experience, right? Now, years later, Dave and his wife and I were friends, we're close. He knows to reach out to me, his family knows to reach out to me first, right? So when their 4-year-old fell and banged her head, she fell off something, they reached out to me. Are you available? Can you help me? Of course, yes. I'd waved them off of several previous CAT scans that they didn't need. This time she was vomiting, right? So she needed to go in, called ahead to Children's, they got seen right away, they went in quickly, right? I don't describe any of this because it's unique, right? We all do this, right? We've all done this all the time. And what we do is someone reaches out to us, connects to us, and we drop what we're doing, and the person on the other end of the phone, because it's always the phone and it's always text message, becomes the most important thing in the world to us, and we deal with their problem. We care about them, right? Because this is what we do. This is the mission of our careers, the mission of our lives is to care about people. And so using that technology, we begin to care about those people. And we navigate them into our systems as we need to. And there's two problems there. One is we drop what we're doing, right? So either we're working and it's hard to drop what we're doing, or we're not working and we shouldn't be working. We work a demanding job. It's exhausting. It's demanding, right? And so to be also having to do that when you're not really working is too bad. But we have to do it because we can't just send people in, right? The system itself doesn't help people. We need to be there to navigate them, and I'm sure that you all have hundreds of examples of helping people, not just with the medical care, but with the navigation, right? This is what happens to most people in our healthcare system, right? They have a problem, they Google it, and then they ask their neighbor, and then another neighbor, and then their mom, and then they call their insurance company, and they get kind of a lousy answer, and then they call their doctor's office, and they talk to a nurse, and the nurse talks to the doctor, and sends it back, and then they get an appointment, and then there's a copay, and then there's a referral, and then there's labs, and then there's another thing, and there's a copay, and then there's insurance, and if they're really lucky and hit that little tiny sliver in the middle, the problem gets fixed. But mostly they get cycled back up to the top again, and if you fall out entirely, you come see us, right? We're the bottom of that Plinko board, right? So if, there were some truly horrific images in that last talk, which are probably gonna burn in your brain far more than this is. But I tried to make it as clean and as clear as possible. The current system is a funnel, right? People enter in the top and they very inefficiently self-navigate through that funnel. They bounce around, right? And at the end of that, they get to us, right? They get to a single sort of high stakes encounter with someone who has to solve all of their needs, right? All of the needs that they've accumulated through this journey in the funnel now come to that clinician. And sometimes we can fix them, but a lot of times you actually don't have the time or the resources back behind you because you're the bottom of the funnel, right? What we would like to see, what I would like to see is us moving from a funnel to a wedge. I think MEP has the abilities to actually be that expert that's at the top of that wedge with resources arrayed behind them so that people don't self-navigate badly through a funnel and then get to a single high-stakes encounter, but have a clinician who can touch them first and then have resources behind them, right? So I've started using this language of apex decision maker, right? So this happens to us all the time in all sorts of environments, right? You walk in to see somebody and they've told their story a dozen times, right? And then finally someone gets to them that actually makes that sort of that ultimate decision, right? About what happens, right? And now we have a teaching obligation. Obviously there's part of that that's related to that. But there's an opportunity for us to use technology to push apex decision makers closer to where patients need them. An MEP can be that set of apex decision makers for acute and unscheduled visits. So what do we do now as apex decision makers? Well, in the emergency department at Washington Hospital Center with the teletriage system, we push apex decision makers right into the intake environment, right? A patient comes into the emergency department and as soon as they're meeting a triage nurse, they're also meeting an emergency physician, right? We provide consultations from our emergency department out to our prompt cares. We navigate those people into our emergency department. We've done 3,400 or so e-visits out to patients in their homes. There is a lot that we're doing now, and there's a lot that could be next, right? So I want to take a little bit of time and talk about sort of what it is that we're doing now. Many of you have actually done this shift and not known that I call it the Mac3. But the bunker in the 7th floor of the East building is the first bunker of a sort of envisioned plan for the MedStar Acute Care Coordinating Center, the Mac3. Right? So what we do out of that environment right now, right, we reach out to a provider in triage, and with many of you in this room, we were successful at demonstrating that you could take an emergency physician out of the actual department, put them remotely, connect them back into the department, demonstrate clinical equivalence, and then spread them such that they could be in multiple places at the same time. We did this between Hospital Center and Good Sam. We learned some lessons, right? There were some things that we would not repeat about what we did at Good Sam, and we pulled back from Good Sam to create some capacity to do some other things. right? That same physician, no additional FTE, is available to prompt care locations, 2 for now, and we've done more than 1,000 consultations from those 2 locations. And they are basically providing the same benefit that most of us get to practice with all the time, right? The ability to say, Manish, what do you think about this? Like, what do you think about this EKG? What do you think about this rash? I've got this difficult case, what do you think, right? We get to do that a lot in our practice environment, and a lot of people who are out in the urgent care environment don't get to do that. And if a patient's leaving the urgent care environment and coming to one of our emergency departments, if they're not there for a good reason, and we don't understand what they're there for, and we don't execute on the plan, that's a very dissatisfying experience. So far, like I said, more than 1,000 of those, about 40-60 split. 40% of those patients are going home from the urgent care, decreasing the number of people who are coming, and 60% of those are being transitioned into our emergency departments. On Friday, I'll be in the bunker for the first pilot day of receiving consultations from the MedStar VNA. I don't know if you know how big the VNA is, but the VNA does 5,000 patient contacts a week. Some of that's PT, OT, but that's 3,700 nursing contacts per week out in the community, right? So that's more than we do in the hospital, and they do it by themselves in a home. Given those numbers, the relatively small number that comes to our emergency department is kind of miraculous, actually. But there's an opportunity for us to allow those nurses not to be out so much on an island, to intervene 2 or 3 days before they need to come to the emergency department. Most of the time they're going to reach out to their treating physician, but there's some gaps there. And we have a technology tool that should allow us to fill that gap. So we've built that. That's what we're going to do today. That's what we're doing this week. But what can we do next, right? So I've spoken to several of you about where teletriage goes next, what emergency departments can be helped by having an intake process that's focused on that apex decision maker being out front, right? Bunker 1 can probably add a little bit, but it can't handle all of it. And if we add from 2 to 14 or 16 prompt cares that we're supporting, we're talking about more capacity that's needed, right? And if we're talking about 3 VNA nurses, that's probably something that we can add on. If we're talking about 3,700 visits a week, that's not something that can be done with our current capacity. So we need to think about how we can create new capacity to do this work. And importantly, we need to figure out how, when it creates value for other parts of our health system, VNA, prompt care, out into the community, how that value is recognized and comes back to us as a group to support our FTEs, our growth, our compensation models. So Jasmine Malik is in the command center today. She's on her clinical shift right now. And so I've just pulled her up from the Perry Hall queue, sent a test to her. Jasmine, I was explaining to the group that actually you'd have a little bit of a break in your clinical time related to an injury. And I'm curious what your experience of work would have been like if when you were injured, when you were in a cast, this had been available as a shift you could do from home.
It would have been fantastic, actually. I had a tri-mal fracture, and it was pretty complicated. I needed hardware, and so I was not really able to do much in the way of, being there physically at work for approximately a full 4 weeks, and then limited on crutches and a kind of like an ankle walker scooter for another 4. And if I had been able to work from home, that would have been ideal. I would have been able to get to work immediately because I was sitting at home doing nothing other than watching Game of Thrones. But yes.
So thanks, Jasmine. I know that you have patients there waiting and are in the middle of a clinical shift, and I don't think you can actually get CME for this.
Okay, but yes, it would have been great if this was actually available when I was actually injured.
Yeah, right. Thanks, Jasmine.
Thanks, Tim.
Bye.
Bye.
We built the original version of this with a company called Amati. Good people built a really good product to do one thing. And in December, we pivoted to a company called Bluestream Health that we're partnering with to create a far more robust ability to do multiple things. One of the things that's different about it is it's web-based. We've worked with IS to make it single sign-on verified, so your MedConnect login takes you right through to Bluestream Health. Your tap and go in the department for our triage nurses takes you right through to teletriage if that's what your verification is. We've done two-factor authentication, which means that you can use it on your home device off the network with two-factor authentication. So we've cleared a fair number of the technical hurdles to get to a place where this is something that can be done from anywhere, including from home. Susie does it from her office as opposed to going over to the bunker. Right? So we are getting there. There are a couple of little technical things, and then there's a conversation about the workflow, the shifts, how we're going to do that, if that's going to be an important thing for our group. So what else can we kind of do, right? So we've talked about this Mac3 provider who's reaching out right now to emergency departments, to prompt cares, to VNA nurses, right? So with that technology platform, web-based, secure, that can take a request on this side, contextualize it, and match it with a remote expert on this side with appropriate context, can do lots of things. So in May, later this month, we'll be starting an initial deployment for sports medicine. And that deployment is basically an athletic trainer on field who can reach out immediately for the care of their injured athlete to one of our sports physicians, right? Divided north and south, divided between ortho and general sports medicine, right? So that if you are injured up in Baltimore with a head injury, you don't get an orthopedic surgeon down at Washington Hospital Center. You get someone in the north who's going to focus on your head injury, right? So, what if that kid needs the emergency department, right? So they should be connected to the emergency department, right? They shouldn't have a disconnect between those two things, right? And maybe we would want to reach out to ortho. Maybe the prompt care would want to reach out to ortho. What are the other things that we would all want to reach out for? What if we created a generic capacity for other kinds of skill sets, not emergency physician skill sets, but other things, right? There's a crying need for access to behavioral health. Everyone will want to reach out to do that. We're working right now with the MedStar Telehealth Innovation Center with our behavioral health service line about how we can achieve acute on-demand consultation from behavioral health and also do collaborative care with primary care and our psychiatrists and LCSWs. The backbone of the infrastructure that we built was actually built to do interpreting services. So you can actually use that same tablet, take it into the room with the patient and use audio only or audio and video translation, completely free of the telehealth, just having nothing to do with that. Or you can flip it on and create an embedded experience of interpreting services, including ASL, whatever language you want, attached to that telehealth interaction, right? That athletic trainer on the field, Spanish-speaking injured kid, can use the same tool that they would be using to reach out to their athletic sports physician to do translation on the field. Yeah, so you can basically just use the tablet or the phone to get audio-only interpreting services through the platform. So if you just need audio, just like we do now with the speakerphone and language line, do the same thing. It's CLI, not language line, but it doesn't matter. If you want to have video also, you can do video also. And if you, the athletic trainer, want to reach out for a Spanish-speaking kid and get sports and the emergency department, you can have all four of those in a video from a field. And there are a handful of things that are just sort of special, just for us, right? So we actually have a fairly robust telestroke program. It's, a vascular neurologist is available to all of our emergency departments. And it's a sort of a mixed bit of coverage, but sort of overnight, it's going to be the vascular neurologist from Georgetown or Hospital Center who's available through MedStar Transport. And it's a pretty manual process, and they actually don't use video all that frequently to do it, but I think it's because it's not easy enough. If we made that a little bit easier, we would be using that pathway a little bit more often. So there's an opportunity for us to be both recipients of remote expert consultation and contributors to that remote expert consultation. And if we build all these things, like everyone will want them, right? So your physician who's off in the POB seeing their patient who's got hypertensive crisis because their blood pressure is 190 over 100 and they have no symptoms whatsoever and they're going to send them to the emergency department. Why don't you just connect with us first and we'll have a chat with you in your office and we can come up with a good plan, right? So it doesn't necessarily have to be from some remote place or something like that. This is an opportunity to coordinate the care that certainly at the hospital center at Georgetown, we get so many of those patients who come from on campus. This is certainly true in other places as well. But there's no reason why we can't just be available to those places that are going to be sending us patients. We've been reasonably successful at convincing MedStar leadership that this is a reasonable vision for the future. I don't know if you've seen this, but this is our new brand campaign.
We have come a long way. If Hippocrates, the father of Western medicine, could see us now, we would blow his mind. Stat. All the amazing advancements in medicine. Great things like tomography and proton therapy. All the implanting, the transplanting, the lasering, and the minimally invasiving. And while science has become better and better at treating people, we can't ever forget the importance of how we simply treat people. At MedStar Health, we believe it doesn't take a brain surgeon to get "you might want us to come to you after surgery," or that the best way to talk to a doctor isn't always in person. And when the contractions are getting, real close, it's good to have a hospital that's, real close. And never forgetting that inside every human body lives a human being. The best of our minds, the best of our hearts. MedStar Health. It's how we treat people.
So you'll notice there in the middle of that, there was a guy on his couch with an ice pack on his knee and a tablet in front of him that was connecting to a video visit. I'm the medical director for the program that would have been using that, and I had no idea who that doctor was. So MedStar eVisit is a collaboration with American Well, which some of you may know is one of the larger telehealth entities that sort of is national commercial direct-to-consumer telehealth. So the majority of these visits are actually done by phone, right? They're mostly done on the mobile platform. And Alison has been doing these visits since October. And you're gonna have to hold up fingers, Alison. You've been seeing patients since October. Between this and other clinical things that you're doing, which we'll talk about in a minute, you've seen hundreds of patients. How many times have you seen those patients by leaving your house? Right. So Alison's been doing meaningful work that she finds enjoyable, that's important to patients, that generates value for our health system, and she does it self-scheduled from home. There you are in your office. So I'm going to go and talk to these people again. Thanks for joining us. Bye. This is a distributed delivery network, and this is the way that we're going to have to be able to do this KERS in a distributed way. So what Alison's actually doing is something called the Connected Clinical Care Resource, the CCCR. And originally what was intended to do was obviously do this sort of direct-to-consumer urgent care, but obviously having her sit around and wait for a trickle of patients to come in and see her didn't make a whole lot of sense. Sometimes she was going to have to refer those people to in-person care, and so we're beginning to talk about that sort of the apex of the wedge about treating patients where they are and directing them to the appropriate sites of care. But sort of sitting around and waiting for people to call was really not going to be an efficient use of the resource, right? So Alison, Amanda, Sarah Greenwood, Nicole Kirk have taken the abnormal lab follow-up program that MEP really perfected and taken a very similar system to prompt care. The way that prompt care used to follow up on abnormal results was individual clinicians and individual sites were making phone calls in between seeing patients. Like high possibility for error, terrible workflow for the clinicians and the places, kind of a lousy experience for patients, and there were some pretty serious misses. And so Amanda especially has taken a group to take all of that work, consolidate it into a centralized workflow, and methodically work through the follow-ups that patients are getting out of prompt care. An acute care follow-up process that allows somebody to also self-scheduled, working from home, connected to our network, and so they're available to do that direct-to-consumer touch, right? So we're relatively early on in the days of the next step in what folks could be doing in that unscheduled acute care is connecting them to MMG primary care, right? Getting them that next day, that 2-day later appointment, sort of getting those resources behind that clinical decision maker and awake behind them to effectively hand them off to the next thing. And that's one of the things we'll be looking to build as we continue to add ability. There's still some hurdles to clear there. Delegation of PAs in Maryland via telehealth is not actually authorized until Monday. We'll be dropping all of our delegation agreements. But we are as on top of this space as we possibly can be, with a group of PAs with vast experience in our emergency departments who are going to be that apex clinical decision maker for unscheduled, acute, urgent care type experiences in the environment. So we have these two things: the Mac3 emergency physicians reaching out within our health system for consultative experience, the CCCR patient facing outward. We need to envision a future in which those two things are combined. And the Mac3 becomes a sort of umbrella of acute care coordination in which we're doing ED optimization and throughput, consultations to prompt care and ambulatory areas, reaching out to the VNA, managing referrals to in-person care, whether that's the emergency department or other places, and thinking about the other things that we can do. Rather than Googling it, can you get one of us to answer your question quickly and efficiently? And can that be meaningful for us and also work that's valuable for the health system such that we can support it? Should we be the engine of DC Fire and EMS's ability to triage people out of 911 transport, right? These are the opportunities that exist for us, and that's the way that we could potentially become the point of that apex to make these decisions. Back to med school to wrap up. My dean's letter was written by Brian Zink before he wrote the first edition of this book, History of Emergency Medicine. The second edition came out. I would suggest that the next edition of this book describes what we do as not just anyone and anything at any time, but increasingly anywhere. I think we're the kind of group that can do this, right? A day like today with SIM and education, a group the size of ours, with the breadth of ours, the academic abilities of ours, the leadership that we have, we can do this. We're in a terrific position to do it. I've talked to a lot of other people who are doing telehealth around the country, and we're in an awesome position, and I'm really excited to be part of this group and figure out what we can do next. Thanks so much.